Sorry, everyone. Hi, I'm the gar.
That's okay. We'll wait till everyone gets connected to the audio and then we'll get started. Okay, we're going to get started. Hi, everyone. My name's Amber Shojai. I'm a third year in the Pitt Occupational Therapy program, and I am one of the chairs for our chapter of COTAD. And thank you all for coming tonight. Tonight, our event is use of a medical interpreter, and we have 3 people from the University of Washington Medical Center here to talk to us today. The 3 people that we have are Nagar, Michelle, and Sungmi, and I'll let them introduce themselves and they can take it from here.
Hi, everyone. My name is Michelle Chilstrom. I'm the manager of interpreter services at the University of Washington Medical Center, and I'm so thrilled to be here to get to see all of you. And I thank Amber for the invitation, and as well as my esteemed colleagues, Nagar and Sungmi, who are going to give some really great information for all of you. So I'll go through a little bit about our program, and then we'll be talking about working with interpreters. And then I think probably the most fun part will be at the end, where there will be some story sharing. And I think there will be some opportunity actually for all of you to bring forward questions or thoughts, or maybe share some experiences that you've had. So it should be really fun. So a little bit about myself. I have worked in interpreter services for the last 20 years. Most of it was in the Midwest in Minnesota, and now 3.5 years ago, I moved to Washington. So it's kind of interesting because there's regional differences, which I'm sure will be coming up as well, as you are all in Pittsburgh. So I want to share a little bit about our services. And so do you mind going to the next? Oh, I can go to the next slide. Can I? Oh, perfect. Okay. So the function of interpreter services is to enable the hospital to provide meaningful access to our patients to communication. And it could be patients who speak other languages, or it also refers to those patients who are deaf or hard of hearing. Or others who have other communication limitations. Our department was actually formed in 1994, which makes it one of the earliest formed departments, at least in the state of Washington and perhaps in the country. And prior to that, the university was accessing just independent contractors, but now we have our own staff of 25 staff interpreters who represent our top languages that we serve, including Spanish, Russian, which is Mandarin, Cantonese, also Korean, Vietnamese, Farsi, Amharic, Arabic, and sign language. So we do provide services in different ways. One of the primary ways is in person, which we typically reserve for those appointments that are more complicated. So you'll have an in-person interpreter with you at the session, which is usually the most preferred modality, but is also the most challenging to arrange for because of so many logistics and the cost of the service. We also do provide a lot of video interpretation, which includes our own staff also providing services over the video, which is basically kind of like this. You're seeing the face of the interpreter and then also hearing the interpreter over the video. And it could be that you're in person with the patient, or it could be that you're doing telemedicine and you have a video on with the interpreter. And then we do telephonic interpretation as well. So why do we provide interpretation? If you don't mind going to the next slide, Amber. So it is a legally mandated service that's provided. And it stems primarily from the Title VI Act of 1964, which does prohibit discrimination based on national origin. And then also, other acts. The one that primarily affects those patients who are deaf or hard of hearing is the Americans with Disabilities Act. And then there's a lot of state laws and, Obamacare or the Accountable Care Act also does require interpreters are accessed. So oftentimes it is something that is not enforced, but it is something that is required. And so you'll see there's a number of lawsuits across the country or settlements where interpreters were not accessed appropriately, especially when there is a negative outcome because of inadequate communication between the patient and the provider. Well, let's go to the next slide. So why is it important to access a certified interpreter? So when we talk about a certified interpreter or a professional interpreter, you also hear the term qualified. They're basically all the same, which means the interpreter has been tested to be fluent in English and then the target language, which could be Spanish, Mandarin, whatever the other language is. And sometimes it's multiple languages that the interpreter also speaks, but they're tested in all of those and they are certified as fluent. And then in addition to that, they are also trained. So the training typically includes the code of ethics, which is that your interpretation must be accurate, do not omit, do not add, you must remain objective, everything is kept confidential. All of those things and more are included in the interpreter code of ethics. And those are kind of what separates a qualified interpreter from someone who is just working ad hoc without any training. And a lot of studies have shown that those interpreters who are trained and qualified are much more accurate than those who are just kind of stepping in and trying to do their best to interpret. So let's go to the next slide. And I think Nagar is going to take over on this one, if that's okay, my esteemed colleague Nagar.
Sure. Now we are talking about why not use service of a family member. A family member is never impartial and is frequently biased, not guided by code of ethics that Michelle already talked about it. An unknown quantity in terms of proficiency in language and medical terminology, that's the other reason. And also, patient may not wish to share his or her health information with the family member, whom may be a minor child or maybe a part of the power relationship within the family. When we do the reminder calls for our appointments 2 days ahead of time, if the patient doesn't pick up the phone, we usually thanking whoever answers the phone politely, and we just say that we're gonna call again. We usually don't leave a message with appointments, especially in MICC, maternity care, or outpatient side. So these are the confidentiality that we always honor. So these are the reasons that we it's better to have an interpreter for appointments rather than using family members. Next slide. Why not rely on patients' language skills? When we refer to patients like as LEP, like limited English proficiency patients, they may not be able to express seriousness of the situation due to the lack of their vocabulary and their basic language abilities. And also, it's happened a lot that they may feel pushed to speak English because of a wish to please or to be helpful. Both provider and patient may be unaware of misunderstanding due to the language problem. An interpreter, we have examples. We had a case that an interpreter was summoned to the ER appointment to interpret for a patient. When she arrived, staff informed her that they were doing just fine in English. The helpful patient nodded yes to almost all of the questions that the staff asked. Even when the question was, do you use crank cocaine? And at this point, the interpreter offered to verify, and indeed her help was needed because the patient just nodded to all of the questions, although the answer was no. So that was an example of it. Or there was another case that during a procedure, a patient was under minimal sedation or local anesthetic, and the doctor assessed the patient rudimentary language skills and dismissed the interpreter. Later, during eye surgery, the patient was unable to communicate why he could not stop shaking. And he had, because of the language, he didn't communicate this with the provider, that he had an involuntary tremor ever since he had stroke. So these are the kind of reasons it's better to have interpreter. Next slide. Why not use a staff? We have a staff, bilingual staff, but we're not sure about the language code, the language competence, and also not sure about the knowledge of medical terminology or concepts. Non-linguistic hospital staff and caregivers are not competent in judging the staff members' knowledge of English or another language. Hospital staff and caregivers may have only a basic knowledge of medical terminology and concepts. Staff may be fully bicultural and bilingual, but have other duties to perform during the day. And staff may be fully proficient, but not able to follow patients to all come from one point to the other point to when they have so many appointments at the hospital. On the other side, I should add that in some of our facilities, like Harborview, which is our sister hospital, they started using an agency to assess the linguistic competency of their bilingual staff. In that case, then they're sure that the staff can do the job. So then we have a list of them and they keep track of them. And then in that case, that's okay. They can use the staff to help with the patient care.
I want to clarify that though.
Sure, go ahead.
Sorry, which is that then that staff member is certified to provide care within their role for the patient in another language, but not to act as an interpreter for a third party. So let's say, for example, that I am a physical therapist and I speak Spanish. I could speak directly to the patient in Spanish, but I could not then interpret for the MA, for example.
That's a good clarification.
Thank you,
yes.
Nigar.
Yes,
Yes.
I want to mention something more. I went to a clinic and this doctor, he speaks pretty good Korean and English. And then we usually don't send an interpreter for his patient, especially for Korean patient. But one time I went there and then doctor tried to interpret it for other doctors' explanation. And soon later, he gave up and he said, let me explain to patient directly because it's a different skill.
Thank you, Sungmi.
You're welcome.
Next slide. When in doubt, when you're not sure if you need an interpreter or not, if possible, please do not dismiss the interpreter. Keep an interpreter available in person or by pager. It happens that patients have surgeries, they have delay. The interpreter cannot sit there just doing nothing. We have other appointments that the interpreter can help. So the interpreter give the phone number for the interpreter services or the pager, and they can page when they're ready to see the patient. So the interpreter can go back and help them. Use teach back to double check the patient's level of understanding by asking questions to make sure that they understand, that the patient understands what the direction was or instruction was. And make sure that you document any unusual circumstances in chart. Document the interpreter's presence on the written consent form. And if you dismiss the interpreter, please document it in the chart. for the future, because nobody is going to remember what happened in that appointment. So to summarize, please do not dismiss interpreter at patients or families members' request, at the suggestion of a staff or other providers. Meaningful access or equal access means that Mr. Hernandez has the same access to medical care or treatment or education that Mrs. Jones has. So that's why the interpreter is needed for appointments. Next, please. Here we want to define the difference between interpreter versus translator. Translator is a person who translates written messages from one language to another. Interpreter is someone who verbally mediates between speakers of different languages. We have different modes of interpretation. Michelle already went over it. We have in-person interpretation that can be done in 3 different ways. One of them is consecutive or sequential interpretation. Speaker says something, speaker pauses. While interpreter speaks, interpreter pauses, the other speaker replies, and then interpreter speaks. And the same thing happens again. Most common examples of this is home visits, conferences, almost all of the medical appointments. And that's what we do here at UW2. Next is sight interpretation, which read aloud into one language what's written in another language. Examples are hands out or consent forms. The third one is simultaneous interpretation, same time interpretation. Interpreter interprets as a speaker speaks, just a few words behind, usually done in large groups. Examples are parent meetings, healthcare institute. Sometimes when they have a tour from maternity units and they give the tour to the families, that's what they do. But it happens often that we do some private touring, and which is much more convenient for families and interpreters rather than doing it in a group. Next slide, please. I wonder if Sungmi, do you want to take over or do you want me to continue?
You can continue. I haven't reviewed the other slides yet.
Okay.
Sorry about that.
That's okay. Next is we're talking about roles of interpreter. Interpreter can have different roles: conduit, clarifier, culture broker, and advocate. In all cases, interpreter conveys everything that's communicated between the provider and patient, neither adding or omitting information, and certainly not censoring or expressing his or her own opinion. In theory, this describes the interpreter as conduit, a person who links two or more other people by creating a communication channel, and illustrates the most fundamental job of the interpreter: to provide seamless and transparent language assistance, to help create the same service situation for the LEP patient as for the native speaker of English. In reality, the interpreter may incorporate a definition of terms that have no intercultural equivalence. Interpreter is considered as clarifier. For example, especially in our Russian patients, when the news is, or they're talking about something negative or it's not nice and negative outcomes, culturally they say God forbidden. So because if the interpreter doesn't start her sentence with God forbidden, then the patient thinks that they're talking about the patient and that's going to happen. So that's something that is added to the interpretation by the interpreter to clarify that this is what the provider is talking about. Or the other word that if the patients are new is refill of medication. That's something that needs to be clarified by the interpreter. In my own language, which is Farsi, we have one word for everything, like arm, hand, everything. So we have to clarify which part, because we have different words in English, but in Farsi it's only one hand, or the leg, foot, So we have to be really kind of clarify what we are talking about. The culture broker role may ask the interpreter to make adjustments for cultural relevance. For example, idioms, sayings, or treatment of delicate topics. For example, ask permission to educate the provider and patient about attitudes or basic philosophies around medicine that are shared by both cultures. One of the examples is cancer. In some of the cultures, they don't want to talk about cancer. Some of them don't even bring the name. They call it Big C. So I was at SCCA, which is a Cancer Care Alliance, and most of the patients are dealing with some sort of cancer. And it was Afghani families. And when I was doing interpretation, I found out that we cannot use cancer. And then I just stopped the whole thing and said that I think we cannot use that word. So I want to make sure that we enter. Of course, before doing that, I stopped the whole thing. And then when there was an opportunity, I went out and I talked to the provider to make sure everyone is on the same page. So I said that I cannot use that word. So please don't use that word. The family member asked it. And as I said, I need to bring it up to the providers because we are saying the same thing. So that's an example of it. Interpreter as advocate sounds very aggressive, but maybe quite subtle. Writing down instruction for patients with dementia or very old, kind of, old patients or with poor vision, making sure that the provider referrals are carried out and future appointments are made are just a few examples of interpreter advocacy. I had a few patients who were very old and then they couldn't remember everything and they wanted to show it to their family. So the provider write down everything. And I usually ask them, please leave enough space for me to write down in between. So for after visit summary. So these are the examples of advocacy that interpreters do in addition to interpreting. Next slide, please.
Nigar, can I just add something to, if we can go back for, oh, here we are for 1 second. One thing that I think is really helpful when you're thinking about the different roles of the interpreter is to think about a triangle. And the conduit role is the base of the work that the interpreter does, which is really you're just going back and forth and you are like basically just saying exactly what the provider says. And then with each of these roles, you go a little bit further up on the triangle in terms of your time. So, okay, next one, you might be clarifying a little bit. The cultural broker should be the one next to the tip. And then the advocate, you don't do nearly as much. You only do that really as needed. So the majority of the time, the interpreter is spent in the role of conduit.
Thank you. Relationships in an interpreted encounter. We have 3 members here. So patient, provider, and interpreter. The main and primary relationship is between patient and provider. So that's the most important aspect of each encounter. And the patient interpreter or provider interpreter are all secondary relationship. But just have it in mind that interpreter is always a part of the care team. And interpreter remains as transparent as possible and not always possible, but it's in particular cases, it's very helpful that interpreter have a kind of communication or kind of facilitate communication with staff before and after the encounter with the provider. Like at UWMC is a teaching hospital. The medical providers rotate frequently to another clinic or service. Interpreters are encouraged to begin their appointment with a 30-second provider pre-session, especially with a provider patient that are meeting for the first time or the interpreter is new. So this is very important. So feel free to use this type of pre-session to quickly establish for all parties the ground rules of communication, especially for inpatients. You're OT, so you want to get into the room. If there's something that's good and it's important to help with a half an hour of OT session, it would be great that before you meet outside the patient room and then you enter the patient room, and that's more helpful. Next slide. Okay, now we want to talk about do's. We have two slides, do's and don'ts. So, but the do's, always greet and address the patient. Speak in the first person and address the patient directly. If culturally appropriate, staff establish eye contact with patients. In some cultures, like Muslims and especially female as patients, but the provider is male, so maybe it's not appropriate to look kind of, establish that eye contact, but these are the things that you're gonna learn kind of about the different culture. Speaks as you normally would with the same pace and content. No need to scream as a patient is deaf or dumb just because the patient does not understand English. It has happened before, believe me. Also position the interpreter and the patient at the right place. Treat the encounter as a normal visit. For example, cover all points you could normally cover. Verify that the patient has understood the education, treatment, or consent form. Instruct patient how to reach you if necessary. Instruct patient to contact interpreter services for help in reaching clinic staff for future questions or concerns. Speak clearly and concisely with pauses for interpretation. Please do not go long sentences because no interpreter can remember the whole kind of very long sentences. Pause at logical points in your instructions or explanation that makes sense. Speak clearly, don't use idiomatic phrases or lots of language-based jokes. We cannot interpret or translate any of those. Even if literally we translate or interpret, it doesn't make sense in the target language. The interpreter may stop patient and the provider for clarification if something was not clear or understood. If the speaker is speaking too fast, the interpreter may use a magic sign to indicate that you need to pause. My magic sign is a T. That shows that the provider needs to stop because it's going too long. Be prepared for a variety of communication styles. Many patients will not know how to work with an interpreter. Be prepared for the runaway conversation and other difficulties. For example, interruption, especially by LEP patient whose comprehension is adequate, but not as good as they think. Number 4, which is very important, is allow appropriate time. Allow extra time for appointment with interpreter. Plan ahead and request for an in-person interpreter if it's needed ahead of time, please, especially for rare languages. Please do your best to keep it on time. These are very important. You cannot rush an appointment or encounter with an interpreter because there's no way. Everything is being said twice in 2 different languages, so needs time. Next slide, please. Don't speak to the interpreter, but the patient, especially while the interpreter is working. The primary focus of the provider is always the patient. You remember that the relationship, the primary is between patient and provider. Even LEP patients are aware of who is being addressed. No side talking while the interpreter is working. Position the interpreter. Please do not position an interpreter inappropriately. The room size and accommodations may dictate a certain positioning, but keep in mind that if the interpreter sits or stands next to the provider, the patient's focus is more likely to remain on the provider. Hard of hearing persons may need the interpreter to be close to them, but may not ask for that. So these are the things that you need to consider. Deaf and hard of hearing persons should not be asked to face their interpreter against a background of bright light. When possible, allow the interpreter to close blinds or position accordingly. Some of these patients need to do lip reading. With pandemic, it's very hard on them because everyone is wearing masks, but we have some clear masks for these interpreters that they use in their appointments to help with the communication and patient care for these patients. Please do not dismiss the interpreter. As mentioned before, LEP patients will be very accommodating when asked to use their English language skills. The most common result is severe curtailment of the amount of information they need to share with the provider. Please do not use tell him or tell her or ask her. It's happening. Really, it's still happening. So please, please do not have a habit of using this. There's no need to say tell her or ask her. The interpreter will be interpreting exactly what you say in the first person directly to the person. And no Google Translate. We've seen that. So it happens that toward the end of the session, they translate in the Google Translate, and then they handed the sentence or a paragraph to the patient. And it happened that they gave it to me. I said, can you read and see it's okay? And then I cannot understand. They said that this is literal translation and the words are correct, but the position of the words in the sentence is not correct and it's not making sense. So please do not use just the Google Translate to translate and hand it to the patient. Typically, the translation does not make sense and it needs to be proofread by someone who is competent in the target language. Next. Story time. I love this part. Flumi, would you like to start the story? Then I'll continue and give some more stories. Just want to remind you about the stories that you told me 2 days ago about OT and shower and all those things.
Oh, yes, yes, yes. Well, I had a patient several years ago, and she had over 7 minutes of anoxemia, and then her brain was a little damaged, and then she has paranoia. And one time she was still in inpatient, and she wanted to have a shower. So I was with the patient and waiting for OT to show up so she could have a shower. And then when male OT came in, she screamed. It's nothing to do with a personal issue or anything. Because the patient had a paranoia and she didn't want the male occupational therapist helping her to take a shower. So in some cases, of course, we are professional, and then a therapist there's no difference between a male and female, but some patients still very uncomfortable when the other sex actually trying to help them taking shower. And I have a very funny story. I went to urology, and the patient had a vasectomy and it went wrong. And then he actually have trouble to deal with the discomfort and pain. And patient was with the provider, and I was sitting behind the curtain because the doctor was about to examine patient, and the patient was explaining his issue. And the provider was looking at the patient, and then when female voice came out about his pain when he has an erection, and then when he had an ejaculation. And then for few minutes, provider couldn't say anything because he couldn't connect my voice and then this very typical male issue. What else I can say? There's a lot of for doing an interpretation for this particular hospital for 15 years. Yeah, I do deal with a lot of do's and don'ts, and then sometimes I myself making mistake about some don'ts. Well, yeah, sometimes it's kind of having a difficult moment that when the patient reveal some things that to me as a medical staff, I have to tell to provider, but if that information came out of me, then it might disservice my patient. So I have to pursue the other way my patient actually reveal himself. So make the provider think is that this patient is willing to work with the hospital and then a more honest person other than hiding and not honest.
Sungmi, do you want to
Yeah.
share because the story or this topic is reminding me of a story that you told me about the transplant patient?
Yes. Yes. I went to a transplant clinic and this patient was about to getting evaluated for the transplant. And during the other question, when the provider said that, does he smoke at all? And the patient said, no, I don't smoke at all. But when the provider went out to do something and then his wife said, no, he's still smoking. And I told the patient and his wife that because it's very particularly important about the issue with the blood vessel and health issues, provider is really strongly concerned about this, the dishonest when the patient doesn't reveal what exactly he or she was doing. So I told them that the hospital clinic time to time randomly test them, and then if they find if he's still smoking, then it's going to be very bad for him. So I told them to volunteer the other information to provider about it. And then when the provider walked in and then patient told the provider, said that thinking about it, and then he's been trying to reduce the amount of smoking, but he still couldn't completely quit yet. So, and then later on, I heard that they were actually delayed going on the list until he completely stopped smoking.
Thank you, Sungmi.
You're welcome.
I had to ask around because you know so many stories, but when you want to think of one, nothing comes to your mind. So I was asking around other interpreters for stories, and one of them was interesting, especially for your group. Diana, our Spanish interpreter, told me that she had a patient who had just recently stroke. She stayed in rehab clinic, rehab for unit for a few weeks, and they were working with it. And then after that, this patient who was from Mexico, she had some outpatient speech therapy, occupation therapy. And one of them, she was not sure it was OT or speech, did assessments. I wanted to see how this patient is doing memory-wise or and mentally. And one of the tests that they do is that, you guys know better than me, but that you describe something and then you want your patient says what it is. So this therapist never did some background, never find out about the background of this patient, how much educated this patient is, how much she knows about everything. She thought that like anyone else, everyone knows about airplane. So the subject was airplane. So nobody knew that this patient didn't know what airplane was or was never been on airplane. So the way that the therapist describe it is that it's dark, you look out, then there is light, and then suddenly you get closer and you arrive. So these patients at boat, ship, and then had no idea that this is the experience that the person can have with the airplane. So because it was not under the interpreter was kind of, I had no idea, but that after the kind of, they found out this airplane, and then the reaction that she saw in the patient, then Diana asked her and said that, do you know what the airplane is? Have you been on the airplane? And she said no. So these are, the patient failed the test, but not because cognitively impaired, but she had no experience about that. So these are the things that beforehand you need to assume, do not assume that everyone knows the basic knowledge. So especially those patients from other countries. So that's an example that was interesting to me when she told me. And then one of the modes of another story that she told me was she was on video, and OT or PT was working with inpatient. And then she said that the video is just right on one spot. It's different from when we are in the room with the other two, like patient and provider. So we see the whole room. But when you're in the video and then the OT or PT talking about it, needs to be very kind of, needs to say everything step by step, especially if there's an inpatient and the patient's speaking so soft so you cannot hear her or him. So these are the important things that you need to consider, especially now that due to pandemic, we're using more of video remote interpreting. And that specific patient actually that had a heart transplant, and it was in pain, and she didn't want anyone touch her just except one PT, and then they didn't couldn't trust any nurses or anyone. So that was the kind of, you start building trust in someone, and especially in that situation that the patient is very sick. So these are the important things to consider. I think that's about it, about the stories.
All right, thank you so much. I learned a lot. I know so many people learned a lot. I have a few questions that were put in the chat. And so I'm just going to read the first one off. You all can answer, or one of you can answer, whatever you guys want to do with that. So the first one is there anything in your code of ethics that talks about if something is against the interpreter's religion? For example, like could an interpreter walk out of an appointment or not show up to an appointment if they're scheduled to interpret for a medical procedure that they don't agree with, like abortion?
Well, the only thing that comes to mind is there is a potential that the interpreter should recuse themselves if there is a conflict of interest. So if the interpreter does not believe that they can accurately interpret because they have too much bias in a specific area, they should recuse themselves. However, I would also say that part of the code of ethic is to be objective. And so I would say as much as possible, the interpreter should attempt to remain and interpret accurately during that session, because it does put the patient and provider in a very difficult situation. And definitely they should disclose that kind of conflict prior to accepting the appointment. I think in certain cultural groups, it is more difficult than others. I know when I was in Minnesota, there were a lot of patients who were Somali, and sometimes it would be that they would even request an interpreter in not the Somali language, but in Italian, for example, because they spoke that language, but they could not within their community. They did not feel comfortable having an interpreter within their community. So One thing that I would also advise if there is a situation like that is perhaps accessing an interpreter over the phone for confidentiality purposes. Sometimes it can be very helpful, especially if there is a small community where people feel very uncomfortable. People know each other, that they may feel that they would be judged. That's another suggestion. I don't know if Sungmi and Nagar have also some things to add.
I know this a young woman who used to be the Korean interpreter in the office. I was told that she never actually went into labor room because during the labor and delivery, it is very bloody and intense, and then she just doesn't go in there. So some other interpreter covers it. So when you deal with the other patient in a certain topic, you think it might be an issue, you have to talk to either agency or interpreter beforehand and then make them accept the job because they could handle it or not. That's, I think, is a pretty more smooth operation.
How about you, Nagar? Any thoughts?
I agree with both of you, but I remember in our own office, we had a few interpreters who did not want to go to any of these kind of appointments. So coordinators knew that, and we knew who goes where or not. So we never signed those appointments to them. And then if it happened, these are these kind of procedures are the ones that are being told before accepting the appointment. So you have time to say yes or no. And if just it happens that in the middle of the discussion, they decide, no, we have to do it, then you can tell them tell the provider what's going on with your, it's conflict of interest, and that they can ask for replacement. In some, you stay till your replacement comes. In some languages that are more common, it's easier to get replacement, like Spanish, Vietnamese, Russian, depends on where in town you're. But then some languages are rare, and it's hard to get replacement. But the other option is to use video. So this interpretive, the interpreter dismisses, get dismissed, then they can use video. And before bringing the interpreter to the room, they need to have a discussion to make sure that it's okay with that interpreter, and they can continue like that.
Okay, so for our next question from the audience, we're going to combine kind of two similar questions. So the first one was asking if the clinician knows a little bit of the language, can they build rapport in the language in addition to using an interpreter? Or should they just stick to English only? And then the other question that was similar was from Laura, and she said she was at a small rural rehab hospital and had a Spanish-speaking patient, and she knows the clinician knows some Spanish, and there was issues with interpreters via video conferencing because the patient had cognitive difficulties and cultural difficulties, so she couldn't really understand using the iPad. So her question was, her supervisor had encouraged her to just speak Spanish with the patient, and she was wondering if there are better ways to advocate to her fieldwork supervisor to access a certified interpreter.
So I would say the first question, it is perfectly fine to use your language skills to build rapport. So if you're just asking, how are you, questions that are not medically related to initiate the conversation, I've seen it used very effectively. And then once you start transitioning to the medical care, it's great for the provider to then transition to the interpreter and say, it's been a lot of fun talking to you. I'm going to speak in English now to allow the interpreter to interpret. It is difficult if you're trying to use your language skills throughout the appointment. little bits here and there, because that can create a difficult language situation for the interpreter to interpret. It's easier if you just stick to English and then allow the interpreter to interpret for the medical piece, but you can definitely use your language skills to build the rapport. That's wonderful. That's actually a really useful thing. And in the second case where the video interpretation was not working well, I do think, well, depending on the situation, it is likely that you did the best that you could do in that situation. However, I would say it's important to advocate, and whether your supervisor needed to speak with the clinic manager or to really communicate that an in-person interpreter was really needed for that appointment. And maybe even to talk about the laws or the requirements. Sometimes it's very challenging. And so I definitely would not beat yourself up about that situation, because you did the best that you could. And in some situations, maybe that was the only solution. However, that's not really ideal, because you're put in a very difficult situation to try to provide the care that you are providing in a language that maybe you either don't feel necessarily comfortable, or there are other people who are coming in and out who do not have access to interpreters. So I would just say in that case to try to advocate for a professional interpreter. And if you're not successful, I mean, there are, depending on how comfortable you feel, you could write a letter to report it, to the CMS, or, but it depends on the situation and how comfortable you feel. Really, it is the requirement of each organization to provide adequate interpretation services. And for the language of Spanish, typically there are interpreters who are available, whether in person, video, or phone. So it's very challenging when the organization does not provide that. And sometimes, unfortunately, I've seen it have to become like a lawsuit or settlement in order for those organizations to really comply with providing the services that are required, which is really unfortunate. So I'm sorry that you were put in that situation. Nagar, Sungmi, do you have any thoughts on either of those 2 points?
Well, therapists, usually physical therapists and occupational therapists often give instruction and then make the patient do their own practice or exercise and then come back, and then you check the progress, right? When you don't speak good patient's language, and then your professionalism and the credibility is going south. And then patient may not listen to you the way you want them to listen, right? So it's going to be the minus your, how can I say, I cannot remember the term, but anyway, the result might be not that successful. From a hospital point of view, and then I'm as a translation coordinator, when I deal with the agency to who actually give a better job at the same time, lower price, I will go for it. So from the hospital point of view, if you actually making 0 expense on interpretation services, they might be happier. But sometimes you really have to firm on yourself that because this service is every visit is a very important, and then you want your patient understand, and you want to understand your patient 100%. So plan ahead as much as possible, and that's only way to go, I believe.
And the second, regarding the second question, if it's really needed, rescheduling the appointment would be an option. So reschedule the appointment, put a note in the appointment note, must have in person, then make sure that everyone can see it, and that everyone who was in charge, like MA and others, make sure that they have an in-person interpreter for that patient. And if the dialect needs to be changed in the system, then that needs to be noted, that needs to be confirmed with the patient by using a telephonic interpreter to make sure that you order the right interpreter. So that's an option. It happens a lot that we have an East Side specialty in Bellevue, clinic in Bellevue, and they have MRI, and then they use contrast for their MRIs. They cannot go, especially if the patients come by themselves, they cannot do administer the contrast without any interpreter. So it has happened that if they couldn't find an interpreter, they have rescheduled the appointment. And then everyone see the notes, and for next time, everyone does its best to make sure that we have an interpreter for this patient.
Thank you. Our next question is, how can we help advocate for medical interpretation services in facilities that may not see their value?
I think the more that you can partner with risk management to bring that forward, the more effective you can be. There have been so many lawsuits and settlements across the country that have been, multi-million-dollar, that a lot of times that's what it takes for the organization to listen, because sometimes, unfortunately, for those that are making the decisions, this is an unreimbursed expense that they don't want to justify, and they don't necessarily see the value. And of course, that you all at the front line, you can see the value right there in terms of the impact on the patient. And so I would just say that that, along with perhaps the comparison of other hospitals providing the service, that it's a best practice. It is a legal requirement, so it's really hard. I think if it's brought forward and asking the hospital why they do not provide a service that is a legal requirement, it would be interesting to see what their response is. Sometimes that is the most effective way. Unfortunately, even though the patient experience should be the most important and patient safety should be the most important component, sometimes it is the risk to the organization that is most listened to.
Well, when the patient comes to hospital and they're getting therapy, and then they want better result and they want to be better, right? And then without good communication, how can you make the result better? When the satisfied patient keeps coming back to your clinic because communication is good, that means better revenue for a hospital. So I think that's the only way.
That's true. Patient care comes first, and one of the main pillar of the, in the missions of most of the facilities. So, and communication has a key role in that. So we know that it's it's service. It goes under the umbrella of social services. So, but at least it's no cost to the patients, which is good. But as Sungmi said, when patients are happy with the communication, they come back to your facility. It happens so often that since we have a good department here to provide this interpreter services, so many patients comes back to the clinic for future or next problems because they know that they're going to have an interpreter, or in some cases hard of hearing patients, for sure they have in-person interpreters. We have some protocols that we go based on that. So like these days, especially after pandemic, we don't send in person to all appointment, but we have a protocol that based on that we sign appointment. So we send in person to new appointments, procedures, surgeries, patients with special needs or the hard of hearing. So when they see the service, they come back to us. So I hope that this is something that those facilities can see it.
Yeah, I was told from a patient who actually was looking for to see doctor, neurosurgery doctor. And one of the referral from the patient's primary care doctor was down in Tacoma or Auburn. Anyway, when the patient called the clinic and they say, if the patient doesn't bring someone to interpret for the patient, they won't take the patient. That was a kind of more than a decade ago, but still, you know, when the patient think that the clinic is actually doesn't take them because the patient's communication skill is the barrier to get a good care, then, you know, who want to go back there? Doesn't, and even someone who has a friend or family member could speak for them.
The other thing that I wanted to highlight, and this is coming more and more to light, is patient equity, diversity, inclusion. And so that's another mode or direction that you could try to advocate, is to go to the EDI officer for the organization, if there is one, and then advocate in that way, because it really is about the patient's right to communicate. Thank you, Sungmi.
Thank you all for those thoughtful answers. I have two things that I want to add from my experiences working with interpreter services. The one thing that I wanted to say was, for those of you who haven't worked with interpreter services before, keeping in mind that your sessions take twice as long because everything is being said in 2 different languages. So that's something to keep in mind when you're thinking about billing, when you're thinking about treating, evaluating. And then also safety. I know that there were situations where I was using an interpreter and the patient was like a little bit delirious and would try to sit down, and I was like, no, don't sit down, and you have to wait for the interpreter to also say the same thing. So that's one thing to keep in mind. The other thing I wanted to mention was Nagar was talking about those masks that they have for patients that are hard of hearing, and I actually took an extra one at the hospital, so I just wanted to show you all. It's a see-through mask. And it works really, really well. So I got to use these with some of my hard of hearing patients while I was at the hospital at UW. So I just thought I'd share that with you. And then the last thing that I wanted to go over was, Nagar, I want you to tell one more story, and I want you to tell the story about the baby over the phone. Do you know what I'm talking about?
Thank you for reminding me of that. It was during pandemic, and we had a pregnant mom from Afghanistan who was at the hospital, and she gave birth to a baby boy, but what is one of those cases that the NICU team, everyone should be ready. So over the week, and it happened over the weekend, I knew that it was happening since I was on the call on the video on Friday. So I was ready for it during the weekend to be ready for help with the interpreting during labor. And then I was ready on call whenever they came, then I was helping them. And finally the baby was born, and they named him Omar. And I still remember the name. It doesn't happen often that I remember the name, but it was one of those extra special. And then I was there a few hours after, or the day after, till the Children's Hospital ambulance came and kind of did the transfer. So that was quite a journey for parents, and still probably is going on, but that was quite a story for me.
It's like my humble brag whenever I talk about my aunt being an interpreter. I always tell that story.
Yeah. That was nice. Yeah. So we have stories like that. That with happy ending.
Yeah. All right. I think that we are out of time, but thank you all so much for coming and talking to all of us. And thank you all to our participants for coming and listening. And then I know we recorded this. A lot of people expressed interest in watching the recording because they weren't able to come tonight. So we appreciate you for letting us do that too. But thank you so much. This was so enlightening.
Thank you.
Thank
That
you,
was
everyone.
very
It's been a
nice.
pleasure. Thank you for
Thank
the
you.
invitation.
Ha-
Thank you,
Have a
Sungi
good
and
night.
Nagar.
You too.
Bye-bye.
Bye-bye. Bye.